I'm Victoria Emerton, and welcome to Behind the Design, brought to you by Design in Mental Health, the leading in-person event connecting professionals from around the world who design, create, manage, and deliver care in the built environment for mental health care. Design in Mental Health takes place in the UK each June and features a comprehensive programme of presentations, panels, and workshops, a free-to-attend exhibition of specialist products and services, and the prestigious Design in Mental Health Awards. Full details about the event can be found at designinmentalhealth.com, including the event dates, the programme details, and how to book your event passes. Today, I'm delighted to be joined by Jill Corbyn, Director of Neurodiverse Connection, and Dr. Philippa Greenfield, Consultant General Adult Psychiatrist at the North London Foundation Trust. Thank you so much for your time today. It's great to see you, and welcome to Behind the Design.
Thanks, lovely to be here.
Yeah, thank you very much.
Jill and Philippa will be speaking at Design in Mental Health, and their presentation title is The Culture of Care, Learning from Trauma-Informed and Autism-Informed Environment Reviews, and that's what we're going to be talking about today. So what is the Culture of Care programme and your roles as part of that?
Thanks, Victoria. So the Culture of Care programme is a programme that's running across England, and it has been co-developed to reimagine care across NHS funded mental health, learning disability and autism inpatient services. It's a quality improvement programme, and at the heart of the culture transformation are three equity principles. They are trauma-informed care, anti-racism and autism-informed approaches. And lived experience is really at the heart of the programme, and the overall vision is for people to be consistently able to access a choice of therapeutic support and to feel safe. So we're part of the programme. We're working on a quality improvement programme with the National Collaborative Centre for Mental Health, Neurodiverse Connection, Black Thrive Global, and the Trauma-Informed Collaborative are all delivery partners in that. And my role and the role of Neurodiverse Connection is to lead on supporting implementation of autism-informed care. Philippa?
Yeah, so my role in particular is around trauma-informed leadership to the programme. I think just saying that feels a little bit strange because, as I say, the whole design and setup of the programme is very much trauma-informed, and as Jill has mentioned, is very much run really, really heavy, importantly, on lived experience leadership. So I suppose my role particularly comes in thinking around how we really think organisation-wide when we're embedding a trauma-informed approach. And what I mean by that really is that we increasingly understand that there is such a high finding of trauma, adversity and inequality amongst those who are using mental health services. And there's such an association between the development of mental health conditions and trauma. And we know that really the highest findings for trauma experiences are amongst those using our inpatient services. So it's really important that when we're thinking about how we design, how we deliver all aspects of care, we have an absolute fundamental understanding of that, and a fundamental understanding of how trauma impacts somebody at all, in so many ways. Neurobiology, their psychology, their social development. So all of these factors have to really underpin how we provide care if we want to provide care that is going to support people to heal from trauma experiences, and also that is going to really ensure that people are safe and not going to come to further harm. So again, it's really my role particularly is how we involve the whole organisations that we're working with and think about all of the aspects of the organisation to ensure that we're able to deliver that in frontline practice and care.
So what have you learned about the similarities and differences between autism-informed care and trauma-informed care as part of this work?
So it's been really interesting working with Jill and colleagues at Neurodiverse Connection on the environment reviews. We both have experience of conducting environment reviews. Me, as I said, coming from a trauma-informed background and thinking very much from that perspective, and Jill thinking very much about the environment, which she'll say more, the autism-informed environment. What's really surprised me is walking around and doing site visits together, how there's been an absolute alignment, I would say, in problem areas in the environment. So as we walk around wards together and think about the environment and just be within the environment, it's really clear to both of us where the problematic areas are. And I think it's really having some discussion. What's been really interesting is the discussion about why and the thinking about why. I think that's probably helped both of us in our thinking as to what is problematic, what is positive in the environment, but also, as I say, really to understand the overlap of what good environments, good, safe and therapeutic environments look like. I suppose, to say a little bit to that, triggers within the environment, and this is something we'll talk more about in our talk, but really thinking about sensory triggers in the environment. For example, loud noises. This can be something, loud, unpredictable noises. This is absolutely something that we know can be a real trigger to somebody feeling unsafe, to a physiological response in somebody's body. So I really have profound impact on how somebody is feeling in a space if there are loud and unpredictable noises. And as I said, the theory and understanding behind that comes absolutely from a trauma perspective of how we understand how that will have an impact. But again, really sort of similar process, as I said, can happen in the sense of those unpredictable stimuli in the environment from an autism-informed perspective. So that's to speak a little bit to I suppose some of the overlaps that I have really started to come across to me, but also thinking about just basic things around the environment, how you feel in a space, whether you have access to light and fresh air, things that we all know, and again the evidence underpins this, but that just feel right, that feel safe. And similarly, areas where we feel unsafe, so things around actually where we're, and something we'll talk more about, where privacy is invaded, things that just in our environment make people feel fundamentally unsafe, where you can't have easy access to staff or people who are in that environment to be able to support you. So I think these are some of the sort of overlaps that are absolutely coming through, but I'm going to hand over to Jill because I'd be interested what you want to say about that.
Thanks, Philippa. Yeah, strong agree, and it's been a really interesting process working together. Certainly there's been more similarities than differences, and it's particularly interesting, I think, that really there haven't been any areas of conflict. There aren't any areas where we need something different for an autism-informed versus a trauma-informed. Actually, there's a strong alignment and support, and like a little bit of theme and variation, a little bit of of difference, but fundamentally person-centered, human rights-based, relational care in comfortable environments is good for everyone. And if we get it right for people with sensory sensitivity, if we get it right for people who've experienced trauma, actually this is a better environment for everybody. And I include the staff in that. A lot of the areas that we find particularly problematic for people with sensory sensitivity, for people who've experienced trauma, for those of us who've experienced both. Actually, these accommodations and adjustments, both to the built environment, but also to our support approach, to our communication, to how we relate and work with and support, like this improves everyone's experience. Like the feedback generally that we have is that this creates and supports better working environments for staff, supports staff retention, supports staff well-being, actually an environment that enables people to have autonomy and rights respected and to be regulated is a really, really good environment for everyone.
That sounds really positive, and we can't at any time forget that there are staff working in these environments, and their well-being needs to be considered as well to make them effective. So what happens in a TI and an AI review?
So they're really experiential. So I mean, essentially we're going into the space and I have a really strong kind of feeling to move away from checklists, because my worry with the checklist is that we become absorbed or focused on the paper, and it kind of becomes a little bit functional. Actually, our primary thing is what does this space feel like? What is our physical experience like? What's happening to my sensory systems? How am I feeling? How's my regulation? And really to experience being in the environment. So we walk around the building, and really observations starting from the car park, like, is it easy to park? What is it like to find the building? How is access? What is the ambience? What's the vibe of the place? And I think often that can kind of be like almost frowned upon, but actually, like, how a place feels is really, really important. Like, it immediately connects to our sense of like connection and belonging and safety. So we're really paying attention to what's happening from a physical perspective, and walking around the building. So in the corridors, in the dining areas, in the lounge, where possible, we do try and see a bedroom, either with someone's permission or if there's a vacant room. And are really trying to experience the space. And during that, we'll speak to staff, and where possible, we also speak to patients about their experience of being in the space. What's it like? What do people struggle with? What does the service struggle with? Are there particular times or areas that are problematic? And talk to people about their approach. How do they support people? How do they work with people? And what is it like to be in this place, in this environment, in this service? Yeah, Philippa, I don't know if you have anything to add.
Yeah, I suppose one of the other things to add that I think has been really interesting when we have walked around and discussed together is absolutely talking to people who are using the service, if people are happy to speak to us at the time. But actually just observing how people are using the space has been something we've talked a lot about, because it really tells you a lot about the built environment. We've talked a lot, again, about how people often pull towards certain places where, which is showing what people need. It's areas where they may feel the most safe, where you notice things are light, not dark and hidden away, or where they are easy in eyesight or easily able to access people or things that they need. So thinking particularly around staff. So I think that's been something else that we've, I suppose, really what builds on this experiential, the importance of doing it in that way, of really just walking through, for me, is absolutely there are certain things that we would look out for and we don't want to miss, or think about, have we considered how somebody is able to access, for example, particularly if you have disabilities, are we thinking about if this is an accessible environment? So we're key things like that we want to ensure that we're looking out for and asking about, but actually just being there, you see by how the space is being used or not being used, and learn so much about the environment, which I think, as Jill has pointed out, if you're fixed on a checklist, these are maybe things that you wouldn't be thinking so much about or paying as much attention to about, but are so important.
Absolutely. And in the work that you're doing, have you spotted some common themes? Can you give us some examples, and what recommendations are you making on the basis of that?
Yeah, certainly. There is some common themes. Some that I think would probably people watching this might guess. So these environments tend to be very noisy. Slamming doors, alarms, sound of people in the space, and the hard surfaces that really exacerbate that is really problematic. They tend to be very bright, overlit, often with automatic lights. So that's also very problematic, and particularly for those of us with photosensitivity. There are accommodations that can be made there. So sometimes around furnishings, so soft furnishings really absorb sound and support a more comfortable environment. Carpet makes a huge difference, and it's interesting how challenging that can be, how much focus there is on infection control versus a comfortable, suitable environment that supports well-being and regulation. Restricted access, I think, is a huge a huge challenge, and particularly where people aren't able to move away from noisy, bright areas. Yeah, it's a really significant barrier, and I think like one of the recommendations that we make is, so make it possible to turn lights off, support people to have quiet spaces that they can access to support their well-being and regulation. Try and accommodate some access to outside space at all times, and that to be freely available. So that's some of the elements in the built environment. I'm gonna save digital technologies for Philippa to speak to in a minute. I think that we have another theme there. But the other thing that I think we're seeing in the support approach, and I think this is particularly related to autistic people, but actually we are seeing this across the board, is positive behaviour support is something that we're seeing implemented sometimes for everybody who's accessing a service or a space, and our position is that doesn't align with the evidence base, that doesn't align with best practice, and I think that can be problematic. So we're offering some alternative suggestions that we think will be more beneficial to supporting well-being and regulation and better outcomes for people there.
I suppose wanted to add a couple of things, because absolutely I agree with everything that Jill has said, and some of the other things I think just to really comment on, and it's really interesting. I mean, I think about my experience having worked in and visited and all, spaces like this for really over 20 years now, and Jill probably similarly also thinking about things that really noticeable and how certain things have changed. One of the things that becomes a real barrier in the environment that we really see is there is an increased focus on mechanistic safety, and when I talk about that, Jill was talking about barriers, so barriers to be able to access outside space. Whenever we think about why is there a barrier to that area, usually the example is because of issues around, say, needing to be anti-ligature or ligature free, which absolutely we need to think about, and absolutely fundamentally we need to think about how we keep people safe. I mean, of course we do, but I suppose what we see in doing that, when we're thinking about anti-ligature environments, the reality of what that often looks like without thinking is you strip our environments absolutely bare. We have harsh environments. We risk having cell-like environments, and I think it's the reality of what we see, and actually that aren't warm, that aren't soothing. And absolutely, if somebody has had experiences, but often people will have had adversarial pathways to care where they've had to come through the criminal justice system, unfortunately, before seeking care. And then yet again, feeling like the reality is you're in a cell. You're here again in that sort of environment, not an environment that is healing and is soothing, where you can have your own things from home. A duvet, something that makes you feel safe. So, physical objects, and there's a real push away from not allowing those sorts of things into buildings. And as I said, it's a real tension, which I think we'll certainly speak more to, but it really means that we're not investing in thinking about psychological safety. And similarly, we see things, and I think that approach, walking into one of the wards that we visited recently together, one of the things similarly to that is big signs on the door: don't bring in this, don't do this here. And, you can't do this, you can't hurt yourself. It's almost saying don't bring difficulties inside here, or don't hurt yourself here, or don't do things that might be harmful. And of course we don't want environments that promote that, but I suppose the message is we can't talk about, we can't think about, we can't hold that experience of distress. Whereas actually what we want to be saying to people is, this is exactly where you want to be able to bring those things, and we want you to not have to hide them away, but to be able to speak to them. So even that sort of messaging that we send to people through our environments and how we use them is so important. And I think the third theme I want to pick up on, but maybe we'll come to this when we think of some of the other questions, is again, and thinking particularly around trauma-informed environments, the move, and I think this fits, there's so many reasons to this, which I hope we can explore more at the conference, but really a move to over-reliance on technology rather than being with people. The amount of times that we're seeing CCTV being part of, being sort of put up, but actually staff not being with people. And really, from a trauma-informed perspective, how does that feel? You're some people, we need privacy, we need safety, yes, we need connection, but there's something about being with somebody and being watched that feels very, very different, especially, as I say, if you are somebody who's experienced trauma in the past. So I think these are some of the common themes, but as I say, but also I think the positive thing is lots of positive work going on in pockets to really say, actually, there are different ways that we can do this that do speak to and manage a lot of these tensions.
So in certain situations, change is needed to implement what you're finding, and change isn't always easy, is it? So what are the barriers to change, and what support do you need from other people to overcome them?
Okay, so maybe I'll start with that, because I think it sort of picks up from where I left on a couple of the points I was talking about in the last question. But I think there are always local challenges and local barriers. We are working, most of the sites that we work across are NHS buildings. We have old sites, we really do. We know that this is a problem in the NHS estate. So there are absolute challenges like that, which this is the building you have, and without a lot of investment, there might be, there are certain structural things that may not be able to change. So of course there are, and there are also, so what you have locally and how you work with that. There are obviously issues there. However, I think that what we really need to acknowledge, and I think what we're very interested in the programme, is there are really a few, some things that that require change above the level of the organisation. So actually, the permission, it's not that people in organisations are saying we don't want that, but if people are being measured nationally around how, if the only way we think about our environments when people are coming around and reviewing our environments, bodies such as the CQC and things like this, if what their checklist says, are you ligature free, is saying, particularly post-pandemic, what are you doing about infection control? If those are the things we're being measured on, and we're not equally and having things, having a really higher level acknowledgement and understanding that actually creating that psychological safety has as much as, if potentially more, but how are we weighting those things together, and what's the guidance to support organisations to act in that way, so that people can often do what they know is the right thing, but they feel able to. Again, everybody, a recent visit, everybody knows that people need access to a garden. Everybody knows that this is going to improve the well-being for the staff, for the people using the ward, and everyone will tell us that. So I don't think anyone within the organisation would disagree with that. But then being stuck as to how to manage that tension in a safe way, and to put yourself out there as an individual organisation, which it is the way it often feels, feels for organisations. It feels like we're taking a risk and we may not be supported to make this change, even though we know it would be helpful. So I think a lot of there are quite a number of barriers that need addressing, and can be addressed at a much higher level with good guidance and good policy, and actually just that really strong acknowledgement from key stakeholders and key leaders that this is important, and this is why. We have the evidence, we have the research, and we have lots of good recommendations. So how at a really high level are we authorising and giving permission for organisations to do the right thing, or to be supported to? So those are some things I wanted to say to that. Jill.
Thanks, Philippa. I really agree with you about the systemic change, and I think before we began this work, we were really thinking about how do we collate what we're learning to bring together the evidence that exists to support further change, like to make it easy for organisations and individuals to access the evidence base, and to support further change. And also what we're learning, or what I'm learning through working with the National Collaborative Centre for Mental Health and the quality improvement approach, is actually there is a lot that we can do immediately. And often small changes make a big difference. So like the big change, the policy stuff, the shift in focus, absolutely, that will really help. And there are things that we can do now. For example, start with turning the lights out. Like have a policy that lights are out unless they need to be on, and give people choice and control around that. Support personalized decision making around access and belongings. Like, take a human rights based approach. Close doors quietly behind us. Let people eat in different rooms. If some people might want to be social, but other people might find that really problematic, and might feel much more comfortable and better able to eat and enjoy their food in a side room, or on their own, or in a smaller group, or by staggering meal times. So I'm really pushing for the big change. Silent alarms, infrastructure, taking walls down, getting rid of nursing officers on wards. All of that, it aligns with the vision set out in the standards, and there are immediate changes we can make now. I was in a learning set as part of the programme this week and heard about one ward that have started lunch clubs and are putting tablecloths and flowers out on tables for lunch. And it changes the environment. It changes how people feel in the space. It changes like the dynamic and the relationship and the mood and the vibe. So like big and small change is really needed here, and like, let's start with the things that we can do. Like we can shift this from where we are.
So in an ideal world, you're making your small changes, which sound fantastic, and in an ideal world you'll get to make your big changes as far as they're permitted. What difference will this make to patients? Maybe even now with the small changes being implemented, we've covered a few examples, but just to sort of tie this off, what difference is this going to make to people?
So I think fundamentally this is about supporting people to be and to feel well and safe and connected and supported in the places that they are. This is about like well-being and comfort, and I guess potentially that heals recovery, potentially that reduces length of stay. Potentially that improves people's outcomes or reduces like their need for other medication or other kind of coercive or harmful practice. It improves their rights. So often what we're seeing is blanket decisions that do not align with the human rights-based approach. But I think also, so often in the work with teams, we'll go in and we will talk about the noise, and we will talk about the lights, and we will talk about the support approach, and they will say, oh yeah, people have told us this. Like, usually what we're saying is not new information, but they haven't had the space, the independent voice, the mechanism to really hear and respond what people have told them, or perhaps haven't had the full understanding of how sensory sensitivity and trauma might impact people from from an embodied perspective. So I think often what we're advocating for is the change that people have already said that they want, have been asking for, and will support them to be more comfortable, more connected, and more well within in a difficult time, in a difficult environment.
I couldn't agree more. And I suppose I just wanted to say one added thing to that, because as I was listening to everything that Jill was saying, I suppose for me, one of the thinking from a trauma, I was thinking about this yesterday, where in relation to one of the ward environments that I was, where I work actually, and just thinking of the experience of walking into that ward. I mean, and what somebody's experience has been often in the build up to that as well. And if you think about this as anybody, as a human being, you have been through something really stressful that may be around symptoms that you're experiencing. It may be a really difficult and stressful situation that you have been in very, very recently. You may be having really distressing symptoms. You may have had to go through a busy A&E unit. You may have unfortunately gone through a police station. you will be in fight or flight, whatever your even if you have had previous trauma experiences before that. What we don't want walking into the door, we want, arguably what we want, if we want therapeutic service, a therapeutic service is somewhere where you walk through the door and you are not still in that fight or flight response. You are not still absolutely petrified of who is going to walk in, what is going to happen to me. You want an environment that creates that feeling where somebody can take a breath and just start to feel safe. And I think all the things we're talking about is really that automatically it is. And I think, unfortunately, the way that we're doing things at the moment is that often the environments, then it just remains within that fight, as you say, fight or flight, that really horrible, psychologically distressing, horrible. And we want people to be able to take a breath, and we want to then be able to say, how can we help you? And I think that experience, that really, that can come across so strongly and can be just so therapeutic from the minute you go in somewhere. So that's what we want to, I think that's really what we just want to achieve, a place where people can really be able to be looked after as well, and just have that real sense of, have a sense of relief, which I think we really need to achieve.
I think there's a lot more to talk about, isn't there? And experiences to share, both from what you've done in your research, and people coming to the event can share their experiences with you, and it's a whole learning experience, getting people of a similar mindset in a room and talking to the greater good. So your presentation title in Manchester is The Culture of Care: Learning from Trauma-Informed and Autism-Informed Environment Reviews. I hope everybody who's watching today has enjoyed and taken something from this conversation, which has been fascinating. So the event takes place on the 3rd and 4th of June in Manchester. Anyone watching this that would like to come along and talk to Jill and Philippa, please do so. Look on the Designer Mental Health website, designermentalhealth.com, for all the information on the programme, the exhibition, and the free content that we have going on within the event as well. So thank you so much for your time today, Jill and Philippa. It's been fascinating to listen to you. I look forward to meeting you in person. We've not met before, in Manchester in June, and thank you for your time today.
Thanks, Victoria.
Thank you.